I'm asked people to sort of take their places because we're starting shortly. If you would move up a bit to leave the chairs at the end there for people who come in later. Just seats on the table here if people want to come and sit and Okay, well, I'd like to welcome you all to this 69th Global Health History Seminar. The topic of the seminar this time is traditional Chinese medicine, and we will have two speakers who will be speaking on this topic, and introducing those in a minute. Just before we start, I'd just like to remind everyone that we're casting this seminar on the internet as a webinar. So please speak to the microphone. On the webinar can also hear. People who are tuning in on the webinar, the opportunity after the two speakers have presented to ask questions. Sure that you send your questions to the host computer, not the presenter, because the presenter won't be able to read them. You need to send them to the administrator on the computer marked host. We'll see. So to welcome everyone today. This is webinars are organised by the Knowledge Management and Sharing Department, KMS. And we also have today present Dr. Jonathan Howett from the University of York, who is the partner organisation on these seminars. And Dr. Howlett is the lecturer in modern Asian history at the University of York, and ask him to introduce our speakers.
Thank you very much. So as Human said, I'm John Howlett, from lecturer in modern Asian history at the University of York. I'd just like to join Human in welcoming you very warmly to the 69th seminar in our Global Health Histories series. And today the topic is traditional Chinese medicine in 1970s Chinese public health. For me personally, it's a real pleasure to be here in Geneva for the first time at the World Health Organization. Representing the University of York, I'd like to thank the Health Organization, in particular Human and Julia, for organising this event and having us along. I'd also like to thank the Wellcome Trust for supporting the initiative. Happy to have two very interesting speakers today. The first of which is Dr. Fang Xiaoping, who joins us from the University of Technology in Sydney. Dr. Fang completed his PhD in 2008 from the National University of Singapore, during which period he also spent a year at the Needham Institute in Cambridge. This summer, very pleased to say that he'll be taking a tenure track assistant professorship at the Nanyang Technological University also in Singapore. So the topic of Dr. Fang's talk today is traditional Chinese medicine in 1970s Chinese public health. And no doubt his talk will touch on many of the very interesting subjects he raises in his 2012 book, Barefoot Doctors and Western Medicine in China, which is a very interesting and very lively account of the attempts of the state in China to construct a national system of primary healthcare. And one of the key themes, which I think will be touched on today, is the role of both traditional Chinese medicine and Western medicine in that system, and of course on its impact on ordinary Chinese people. The speaker is Dr. Zhang from WHO. Joining the WHO, Dr. Zhang worked as a researcher on traditional Chinese medicine and as a doctor. And before joining the WHO, he also worked for the Chinese government on healthcare, traditional Chinese medicine and its role in healthcare provision, and also advancing international cooperation. Today he's here representing the WHO's traditional and complementary medicine unit. And Dr. Fang's, Dr. Zhang's talk today will focus on putting some of Dr. Fang's work in the WHO perspective. So thank you very much.
Yeah. Thank you so much, Dr. Holman and Dr. Howlett, for chairing this session. I have been profoundly honored to have been invited to give a seminar talk in a global health history seminar series in the World Health Organization, and for devoting some of your precious time to attend my presentation. Few years, I have researched on the social history of medicine in rural after 1949. I recently completed my first book, The Doctors in Western Medicine in China, of my PhD dissertation, which was published by the University of Rochester Press in December 2012. In 1998, at the end of the Cultural Revolution, the Chinese government, Communist Party, endorsed a radical new system of healthcare delivery for the rural masses. Every village has at least one barefoot doctor to provide the basic medical care, create a new network of healthcare services for the very first time. This is the lowest level of a three-tier state medical system that provides the county, the county, and related levels. With the creation of the rural reform policies, dismantling of the people's system in 1978, the BETTER program began to gradually disintegrate. The doctors who passed medical examination and continued practicing medicine in villages were named village doctors. Their appearance doctors attract the attention of the scholars and social commentators. Doctor program studied both inside and outside of China as a low-cost solution built around easily available indigenous medicine. Beautifully revolutionary image. People who waited undaunted through the months of the rice paddies to provide the medical services in Chairman Mao's call to strip rural areas in medical and health work. Treatment was popularly described as the one silver needle and a bunch of herbs, a acupuncture and Chinese herbal medicine, but they combined and Western medicine into practice. To create rural medical systems, the better cooperative medical services have associated with improvements in basic health indicators under the socialism after the founding of the People's Republic of China in 1949. In the late 70s, the World Organization promoted the Chinese system as model for the primary health care for developing countries or the third world. Research is beyond the nostalgic view of barefoot doctors, calling to the questions orthodox interpretations that dominate the present scholarship of public health in China. and reinterprets the role of traditional Chinese medicine in public health in China in the 1970s. It is the Barefoot Doctor in context of the history of the debate concerning how the legitimacy of Chinese medicine has been challenged by the Western medicine since the late 20th century. The study is based on the field work in the 7 counties in Hangzhou Prefecture, the Zhang province in eastern China, from 2003 to 2011. The materials include archive documents and local gazetteers. In addition, I will examine the introduction of the Western medicine into rural China in terms of knowledge, pharmaceuticals, and healings during the 1970s. The next transmission and structure. From the 1950s, the traditional family and apprenticeship-based knowledge transmission modes, whose were mainly conformed to the local community, start to change gradually. Meanwhile, the Western medical knowledge had already entered Chinese villages and encountered Chinese medicine mainly through the vaccination program. A catalyst for the change was the fact that the Barefoot Doctor showed a new type of person into positions of authority in villages. During the 70s, the criteria for the Barefoot Doctor, including the young, educated, and in contrast to the old style villagers, the Barefoot Doctors both the Chinese and Western medical knowledge, take information from both the Western style physicians and the legitimate focal healers. However, the medical doctors were Western medicine-oriented doctors from outside of our local community, such as county health schools. Training was further facilitated by the appearance of a unified medical textbook. For the Barefoot Doctors, textbooks that actually targeted them were soon widespread. In general, the content of these books was oriented more towards Western medicine knowledge, though this was combined with the Chinese medicine to a certain degree, as the previous scholars has argued. A few factors affected the Barefoot Doctor's knowledge structure. The Barefoot Doctor's low literacy levels mean develop practical operation skills, such as administering the injections and preparing the intravenous strips and dispensing the medicines according to the illustrated instruction labels on the bottles, or by digging up the herbal medicines. The short-term training made theoretical and practical self-study an alternative way for the Barefoot Doctor to acquire the medical knowledge. The Barefoot Doctor limited training and self-study made them more inclined to adopt the simple medical knowledge and the practical skills of the Western medicine, the more complicated custom of the Chinese medicine, though the latter was acquired in both study and practice. This was influenced by the production of the pharmaceuticals, which allowed the Barefoot Doctors to develop a Western-influenced medical structure. It was also accompanied by the transformation of healers through the acquisition of the modern medical knowledge in the farming communities, which began in early 1950s, and coincided with the natural agents of the local healers with the local community. Around all Chinese medicine doctors as the first agents of the induction of Western medical knowledge into this countryside. These thoughts faded away as a result of the spread of the very knowledge that helped introduce in their own communities. So now the second issue, the epidemic transition in pharmaceuticals in villages. So let's look at the epidemic transition. Barefoot doctors were popularized in the village of the Hangzhou prefecture. There were remaining infectious disease, which accounted for 97.1% of the total patients from the infectious disease in the 1950s and 92.6% in the 1960s. For parasitic disease, zoonosis, malaria, and filariasis and hookworm were also rampant. Because of the continuous large-scale public health campaigns, infectious disease no longer posed a serious danger to the villages by the early 1970s, just after the advent of the barefoot doctors in the villages. The vision regarding the parasitic disease also improved greatly from the mid-1950s to the end of the barefoot doctors in late 1960s, as illustrated by the case of the schistosomiasis. The disease mode of the rural China, except in rural Hangzhou prefecture and Zhejiang province, epidemic transition from the infectious and the parasitic disease to chronic disease in the early 1970s and not the early 1980s, as the current scholarship widely argues. It's significant that the pharmaceutical reaches the villages. The pharmaceutical company was first started in the early 1950s, with the managing the sale and the supplies of the medicines with county through the clinic pharmacies, supply and marketing cooperative medicine shops at the district and the county levels, as well as some of the medicine peddlers. By the 1960s, all villages were more familiar with the cheapest, most common medicines than they had been in the early 1950s. The sending of the medicines to the countryside was still not popularized by the late 1960s. In the rural areas, this pharmaceutical sales network only reached the new level. Coalitions established with the popularization of barefoot doctors in China after 1968. The means expanded the pharmaceutical sales network throughout China at rapid pace, while the whole pharmaceutical network was extended to the levels. Each county's People's Disease Prevention and Treatment Hospital commissioned each commune clinic to serve as a medicine wholesaler. The core medical stations could buy the Chinese and Western medicines and medical instruments at a wholesale prices. With access to pharmaceuticals, the network, price, and quantity were all crucial factors. In the 1950s and the 1960s, pharmaceutical prices were still higher compared with the village's incomes. For example, in 1957, a bottle of the tetracycline cost 170.3 yuan. The one bottle, there were one tablet in the one bottle. Yet, the average annual income of the villagers that year was less than 50 yuan. So the villagers would have to work for 3 years to buy a single bottle of tetracycline. The reduction of the prices was a crucial factor for the villages. On the 1st, 1969, prices for 1,230 kinds of the antibiotics, reducing medicines, pain-relieving medicines, vitamins, and medicines were reduced by 37.2%. Products constitute about 72.1% of the total pharmaceuticals available at the time. By 1971, the medicine prices was only 1/5 of the prices they had been in 1949. Pharmaceutical for common disease, the vaccines or biological products were of significance for combating the acute epidemic disease. By 1990, vaccines had already been administered in Hangzhou Prefecture, Zhejiang Province. This covered 18 of the epidemic diseases that occurred regularly in rural Hangzhou areas during the late 1960s. For the most serious epidemic disease, measles and epidemic meningitis were invented and applied by 1970. As mortality rates of the measles and epidemic meningitis were the highest of all the infectious diseases affecting rural China, the invention and application of vaccines for them were of great significance. The rates of infectious disease started to decline after 1968 and to the lowest level by 1960, where they have remained ever since. In this system, Western medicine was not only available but also accessible to villagers for the first time because of the significant reduction in the prices of the Western medicine. Chinese medicine received the renewed official legitimacy and within a nationalist network, but it was also popularized because of its relative affordability compared to Western medicine. This of a nationwide pharmaceutical scheme combined with the spread of the barefoot doctors that the two kinds of pharmaceutical in the village's medical areas on a large scale for the first time in the social history of medicine in China. However, the Chinese medicine encountered difficulties in terms of the constant, reliable supply sources and faced dilemmas when it was promoted on a large scale. Without the situation for Chinese herbal medicine was not optimistic in Hangzhou Prefecture and the Zhejiang Province. For the Barefoot Doctor program was 1976 of the percentage of the production brigade implementing the cooperative medical services. However, only 43.16% of the total number of production brigades implement the cooperative medical services. Also, gathered and planted the Chinese medicine herbs themselves. So, in the better program, first the real context in which Chinese and Western medicine compete in the village's medical world. Now this issue, the style and the medical belief. The Chinese herbal medicine was described as playing the heroic role in rural medicine. It's with the silver needle and a bunch of herbs that symbolize these two practices. The barefoot doctor becomes the official representation of the revolutionary health. However, the healers used by barefoot doctors in daily practice were different from those images constructed in revolutionary discourse. A variety of the different methods applied by barefoot doctors in diagnosis, Chinese herbal medicine, acupuncture, and Western medicine. Although the doctors also employed Chinese medicine, they tended to increasingly apply the modern medical instruments, albeit rudimentary, and prescribe the Western medicine tablets. This resulted from a combination of the training and the availability and the convenience of the Western medicine, as well as the revolutionary new knowledge structure that emerged around the health delivery since 1949. Major as a parent gain a great degree of access to the healing style and techniques, ideas about the comparative values of Chinese and Western medicine. For example, the Chinese and Western medicines were considered to have different strengths and weaknesses in terms of treating the symptom and the roots, or being quick and slow, or being better suited for some conditions rather than others. Because long-term stability of medical station keeps in the villages, the scale of the pharmaceutical there underwent a significant change during the 1970s. As of quantity, types, and sales income of the various pharmaceuticals based on a detailed data of the Jianze County Health Bureau of the Hangzhou Prefecture may reflect the structural change brought by the advent of Barefoot doctors. Cooperative medical stations and the Barefoot doctor program promoted nationwide in 1970, which therefore could be seen a watershed year in terms of the medicine consumption. The issue to be explored is the medical expenditure, both total and per capita. By 1990, the total medicine expenditure in Jianze County remains 1 million yuan, which did not include the cost of the medical instruments and the chemical solutions. However, the total medicine expenditure increased to 1.2 million yuan in the second year, that's 1991, and continued to increase year by year from then on. In the same way, the medicine expenditure per capita in Jianze County was dipped under the 3 yuan before the year 1970, around 4 yuan in 1971, and it has continued to increase steadily ever since. Indicates that the establishment of medical stations and the presence of the doctors increase the pharmaceutical consumption significantly. A issue was the different kinds of the pharmaceuticals being consumed during this period. What's the consumption of the Chinese materia medica, like when the Chinese herbal medicine campaign was promoted in villages during the 1970s? According to the statistic concerning the 30 kinds of the common Chinese materia medica in Jianze County, the average consumption rate per capita was approximately 30 grams before 1969. The rate stayed the same in 1970, but suddenly increased to the 40 grams in 1971, before falling at between 40 and 50 grams from 1971 to 1982. And that the average consumption rate of the Chinese materia medica saw no significant change in conjunction with the Chinese herbal medicine campaign. Most of the Chinese materia medica consumed, therefore, remained relatively stable until 1983, though total sales income slowly increased because the prices increased. Percentage of the total sales of all pharmaceuticals, Chinese materia medica increased from the 16.4% in 1961 to 1969 to the 18.3% in 1970 to 1978, before time to the 40.9% from 1979 to 1983. While the consumption of the Chinese material medica declined, that of the Chinese patent medicine increased. These changes were reflected in the same volumes of the Chinese patent medicine. In 2020, the Chinese patent medicine only accounted for 7.8% of the total sales incomes of various pharmaceuticals from 1961 to 1969, before rising to 8% in 1970, and then 12.7% in 1971, and 13.3% in 1971, or from 1971 to 1978. The proportion of the medicines of total pharmaceutical sales income only exceeded that of the Chinese materia medica for the first time in 1979, when the Barefoot Doctor program basically stopped running in 1983. The percentage jumped to 24.7% in Jianda County. In the whole areas of the Hangzhou Chinese and Western pharmaceutical stations, which include both areas, rural areas and urban areas, sales of the Chinese patent medicine increased by only 60.2% from 1959 to 1979. But the figures soared to 317.3% in 1983 and 600.1% in 1987. However, this increase can be through the sales of nutritional and tonic medicines rather than the curative pharmaceuticals. According to the statistical data for 70 major Chinese patent medicines in the wholesale areas supplied by the Hangzhou Chinese and Western pharmaceutical stations, the sales incomes for the nutritional and tonic medicines increased steeply, as the percentage share of the Chinese patent medicine sales grew from the 33.29% in 1979 to 38.32% in 1980. Sales eventually surpassed those of the curative Chinese patent medicine, represented an average rate of the 51.77% of the total sales between 1981 and 1985. The volumes become the sole factors behind the increased percentage of Chinese medicine, including Chinese medicine, referring to the Chinese medica and patent medicine, or the total pharmaceutical sales. But in Jiangxi, the average percentage of Chinese medicine over the total increased from the 24.2% from 1961 to 1969 to the 31.6% from 1970 to 1978, before soaring to the 40.8% from 1979 to 1987. This increasing the percentage of the sales income represented by Chinese medicine does indicate a decrease in the percentage represented by the Western pharmaceuticals. The actual quantity of Western pharmaceutical consumed has been increasing steadily over the years. As discussed earlier, Western pharmaceutical prices was by about 37% in 1969, and there were further reductions in 1974 and 1984. Therefore, increasing expenditure and decreasing prices resulted in a significant increase of Western pharmaceutical consumption throughout the 1970s. And antibiotics dominated these Western medicines. The Barefoot Doctor and the establishment of the medical stations also led to the overuse of pharmaceutical Chinese villages from the very beginning of the Barefoot Doctor program in 1970s. Barefoot doctors were entitled to prescribe the drugs without researching, with no supervision. When Lu was initiated in the early 1980s, Barefoot doctors become the private medical practitioners because no fees were usually charged for consultations and examinations. Villages come to depend on profits from pharmaceuticals sales to maintain the daily operation. Prescribing Western medicine became even more popular. By the 1990s, there were still no regulations or limits to the prescription of medicines by barefoot doctors. The distinction between the prescription medicines and over-the-counter medicine was not followed rigorously. Meanwhile, the villagers were becoming more and more familiar with the medicines and they usually asked for the medical drugs. And more significantly, patients themselves asked for the glucose inconvenience drips to a certain extent. The drip therapy became the kind of panacea for the villagers. The February 2010 edition of Economic Survey China issued by the Organization for the Economic Cooperation and Development. This use is particularly common among doctors who have an incentive to overprescribe. They rely on the sales of medicine for part of the income. For nearly 3 of the patients surveyed, the medicine prescribed was antibiotics, while 1/6 were prescribed 2 or more drugs. Okay, that's presentation. Thank you so much.
I'd also like to thank Humin for the organization of this seminar. So thanks to Dr. Holly for being a moderator, also supporting this seminar. For Dr. Fang's presentation, very much focus China, focus medicine, and also focus on barefoot doctors and that period of China, and also many examples from one province of China. So my presentation is going to not much focus, but just very brief introduction about the global side and the traditional medicine. Not very much focus on Chinese medicine, give you a general idea about traditional medicine worldwide. Divided in 3 parts. Firstly is the current situation. Secondly is what has been done very briefly by WHO, and so priorities in the future. You may know that we call traditional medicine or call traditional and complementary medicine. Divided, of course, medication and non-medication. Medication majority. More than 90%, of course, is the herbal plants, or including minerals and animal materials. For the cases, some examples, for example, acupuncture, manual therapies, or Tai Chi or others, exercises, Qigong, Qi from Chinese medicine or Yoga from India, and others, of course, including the physical or mental therapies, etc. Generally, some examples that's worldwide popular use. We can see traditional Chinese medicine, for example, Ayurveda and Unani Arabic medicine, homeopathy, chiropractic, osteopathy, naturopathy. Either a system, for example, traditional Chinese medicine, Indian medicine or Unani medicine, or as a therapy, like chiropractic or osteopathy. Also, acupuncture, now on the survey, is most popular therapies, but that simply belong to Chinese medicine. To introduce you to have an idea about the diversity of traditional medicine. That is linked to the culture, to the history of each community, even not talking about the country. For example, in African region, some from healers, that's part of generation, but already part of the resources of the herbs. Even in Indonesia, jamu popular use not only in Indonesia but even neighboring countries. European countries usually call complementary or alternative medicine. Example, the Tuina or acupuncture actually from Asia part, but also some locally they produce, for example, homeopathy. It's originally from Germany, but also we generally call complementary or alternative medicine. Mongolia calls traditional medicine laws also. Other countries, you can see some example, Latin America, even also long history. Nuo Tai herbal medicine and also Nuo Tai Tuina. It's different with Chinese Tuina therapies. This is an idea about diversity. Also, I would like to introduce some the progress actually for the last decade. You can see that when WHO launched the first global strategy on traditional medicine in 2002, 10 years ago, some progress in the member states. Your number of member states with traditional medicine policy before is about 25 countries. Now it's 69 of the 70 countries. They established particular policy on traditional medicine. And regulations of our member states on herbal medicines, because it's the majority part of traditional medicine. From 65, now it's to almost 120 on the report from countries nowadays. Particularly for herbal medicines, majority of countries now regulations already. For the research side, the review of also the other indicator is the research institute. For which we set this indicator because it's very much linked to the use of traditional medicine. You can see that from 19 countries to 73 countries established national level of research institute for traditional medicine. This very much improving rational use of traditional medicine. So the other figures that based on the recent report from member state 129, you can see for the regulation on providers. Now on the reporting countries established regulation on providers. So it's less than the regulation on herbal medicines. However, it's still now almost 50% of country regulation on providers. Because if we ensure the effective services, we need not only regulation on herbal medicines products, but also need regulation on providers and practice. So the providers regulation is also important. WHO now is very much paying attention, and in the future we will emphasize this part of work. Also, education of traditional medicine provider also important indicator. Based on the report, now you see about 30 countries, the 30% of country, they established and beyond level. Here also including the short-term certificate training. More countries, a lot of. Just relating to the we call high-level systematic training. That's was already 30%. This is a figure I think is encouraging. Of course, we need to improve it because education, training of providers very important for the quality and safety of the services of traditional medicine globally. The reporting from member states challenge also the critical. What are the priority challenges the member states think? Now, you can say number one, lack of research data. And the second one is control, regulate the advertising and claims, and regulate still mechanisms. What's the mechanism for regulating herbal products? Not just establish regulation alone, but also operate mechanisms and also the mechanisms for progress. And they point out lack of financial support for research is also a key issue, because we now always promoting evidence-based medicine, including traditional medicine. We also realized lack of research data nationally for traditional medicine. Why lack of research data? One of the key and the reason is lack of research data is actually many member states or academic or other institutions, they to realize the importance of research, so that financial support to research is comparatively very lower than others. So that's one of the keys. That's why now we lack of research data on traditional medicine. Also, based on the challenges, they request WHO, of course, support member states in the research, the regulation, and of course others you can see. These other some brief about the current situation. So I would like to say what has been done very briefly by WHO. This is the 2002 first global strategy, and the strategy we set 4 objectives and also with indicators: policy, safety, efficacy, exercise, and also residual use, much relating to the research. And also after that, WHO launched, for example, the conducted global survey first one, and also after 2005, WHO strategy for traditional medicine combined into the medicines strategy 2007 and 2013. Also published other guidelines, benchmarks, and when in 2009, resolution on traditional medicine. In the past, of course, based on the strategy and the resolutions on traditional medicine, on the policy regulation side, WHO with publications based on the global survey. Also, other many documents, including the technical guidelines, safety, quality, efficacy side. Here is only examples, either GMP monograph, research methodology, safety side, and even other documents. Here's only some examples. And recently, 2010 and 11, we also published several documents. For example, here is monograph for newly independent countries. Here is for homeopathy, safety issues for preparation. Here's quality control method for medicines. And also benchmarks for the training for different treatments or therapies. Here you see Chinese naturopathy, osteopathy, Nuo Tai, Chinese medicine, Ayurveda, Unani, and so you know that WHO since 2006 established a regulatory work. That's 12 members, including 22 countries and 3 regional bodies, EU and South. That's regulatory bodies as FDA and also in regular work, particularly WHO provides not only administrative members and also every year meeting and provide mandate for data communication and monitoring. So there are working groups under the network that's very actively working, cooperation, collaboration, and through that net even very active now. In one country, it's a new herb or some peers, and they will share information very quickly other experienced countries. This very briefly for what we have done in the past. The part is for the priorities in the near future. WHO now is in the process of developing new global strategy for the next 10 years. General focus is supporting member states from recognition of existence in your country to appropriate regulation of traditional into the national health system. The goals now is to harness, of course, the potential contribution by health, wellness, person-centered healthcare in member states. Also, promote the safe and effective use, regulation, evaluation, and integration, product practitioners and practice. That is now under discussion in this document. First one, we highlight knowledge-based management through appropriate national policies. This is the knowledge base fostering the management and appropriate policy. Secondly, of course, we emphasize the quality, safety, and effectiveness through the appropriate regulation. Regulation not only for products, but also for practitioners. We promote access, talk about universal health coverage through appropriate integration to different services in healthcare delivery and self-care, because this is also the important part of traditional medicine. A large population use traditional medicine daily for self-healthcare. Of course, we are aiming to support member states on research build knowledge base, support member states on regulation through benchmarks, guidelines, terminologies, classifications. Now we are working with CTS, WHO, other works. Of course, innovation is appropriate, improving the access to traditional medicine, the service delivery models in traditional medicine, classification, of course, education, and to consumers, all issues very much relating to implement those strategy. My is clear. This year we are going to finalize it, and next year, of course, will be discussed during EP or WHA. I would like to emphasize when talking about regulation, of course, the three parts, not only the products, and also we will emphasize nowadays evaluation of the regulation, of course, from the coverage. For the evaluation assessment side, I'd like to illustrate one example. This is from China. From China, you know that 1996, that year starting, that China is monitoring center. They monitoring the practice of traditional Chinese medicine hospitals. Later now expansion to monitoring the healthcare already. So I just show you firstly the evaluation is important. Secondly, how to strengthening or emphasizing the monitoring. They had to work. They set up an indicator system and also software database. There is a team particularly for this. And also, you know that, for example, they stratified cluster and randomized sampling samples. Here is 100 hospitals, which the sampling plus combination of stratified cluster from the whole country, 1,000 hospitals. That selected these 100 examples from different East, Central China, Western China, because you know that in China, a big country, and economic and social levels are different. Also use a Western example to represent now in East part, developed part. So they stratified cluster, different regions. Also, different levels, each province, city, and divided the different regions and different levels, and then they randomized sampling. So that's why this 100 hospitals come out. So the results could represent the whole body of the 3,000 hospitals in China. This, I mean, they already work. So the service volume or service human resources management side, they could monitor cost even of per prescription. I mean, they can monitor from that. This is here only example. Here also with a photo, looks like a bank, but actually it's a Chinese hospital. Modernized. It's not any the poor facility or the traditional anymore. Inside is traditional medicine, of course. And lastly, I would like to talk about the integration. What's the integration traditional medicine in international health system? As you know, the principally Margaret Chen already talked about in 2008 that in there is the first WHO Congress on traditional medicine. She said that two systems, traditional or Western, need not each other. Within context, primary care, they can play in the benefits of harmony. It's the features of each and for each weakness. This is, of course, the principle. And also on the implementation side and also the practical side. So the whole health system, from the leadership to the top of the system, of course, we intend to support member states to integrate the traditional medicine, if appropriate for that country, of the health system building blocks, put it into the policy dialogue, the strategy national plan, and the regulation management of financial workforce, the infrastructure, and also information side. Every component or building block of the health system should include traditional medicine as part of the building block. And the delivery side and provide both so-called conventional medicine and traditional complementary medicine. Promote universal coverage, cost effective anyway, based on the model of primary health care. In this case, we can provide the health security, health equity, social inclusion, and also trust in health to people, to the consumers in that country. Of course, thirdly, our goal is to benefit the patient or public, because they going to visit the doctors or disease, either modern medicine or traditional medicine, they have more choices. Can choose from the two. So finally, will benefit the public. This is the goal of traditional medicine team here in WHO. Thank you.
Okay, so we're now open for questions, either from our audience here or the people who are joining us on the webinar. So if you want to make a question, address a question to the host computer.
Thank you very much for a very useful presentation. We have been working with the traditional medicine department with our esteemed colleague, Dr. Zhang, on making a classification terminology about the traditional medicine and complementary medicine. So I would like to make a few points in 2 minutes. As you have understood from the presentation, traditional medicine is a significant part of the healthcare. If you go to China, I think global indicators show that 30% of the healthcare or so is delivered in traditional medicine. But not only in China, so it's in Korea. In China, 70% of the prescriptions use one of the combo medication, which is traditional medicine. So it's not only in Asia, in India, or Southeast Asia, but it's been exported to Europe, to Western countries, and Dr. Zhang showed that there are different types of traditional medicine all over the world. And when it comes to WHO, how we monitor and evaluate it, unfortunately, WHO has turned a blind eye to traditional medicine. I mean, notwithstanding the efforts on the department, for example, with the World Health Report 2006 about human sources for health, there is a footnote about traditional medicine practitioners not counted. Okay, look into the health expenditure. We don't have expenditure data on traditional medicine. We don't have patient safety or assurance data on traditional medicine products. So unless there are standards in this area to define what these things are, no health information comes with it. How will you evaluate it? So and I fully subscribe to what the Dr. Zhang gave from Dr. Zhang, when medicine and traditional medicine should not clash but complement each other, all in information systems and all WHO's work. So like the Olympic Games, you have included Taekwondo, you should include traditional medicine into the same standards of and evaluating the impact, safety, effectiveness, quality, prevalence, and so forth. So this is a very important thing. And for that, I comment, and I think we can discuss more about how this could be a benchmark for evaluating the new traditional medicine strategy. But my question is to this part of the Barefoot practice and so on. For example, for historical reasons, if you take schistosomiasis in China or malaria in China, epidemiologists and health services researchers, they're all the same magnitude. They're almost 0.8 million cases in China on both things. And in one case, artemisinin, in fact, it's a traditional Chinese medicine that comes now. It is also Western medicine too, which has been. But for schisto, there was no such an equivalent from traditional Chinese medicine, is it? And how do you tease apart the impact of the traditional medicine versus Western medicine? And in all these conditions, it's also improvement of, for example, lifestyle, environmental interventions, prevention of flooding, mosquito eradication, and so forth, to the burden of disease. Thank you.
Yeah, Dr. Fang, I wanted to ask you, you mentioned a 37% price reduction in 1969. What drove that price reduction and the subsequent price reductions for Western medicine? Was it a policy decision? Was it local production rather than importation? How was that affected?
I'm not following my own instructions. Okay, do the speakers want to reply to those two questions? Want to start first?
For the second question, the reduction of the 37% of the what we call the prices in 1969, it was only the national policies. It was this. Because at the time, the government say in answer to the mouse call, to the healthcare, to the peasants in the villages. So for the productions, that topic I will be exploring. Yeah. Question for the eradication of the schistosomiasis at the campaign in the 1950s. Because I only major in the medical history, in the modern science history, I do not have the training in medical sciences. But as far as the materials I have read and collected, the basic treatment method come from the Western medicines. Because for the schistosomes in the records of the traditional Chinese medicines. We cannot find the equivalent to the terms or similar description of the symptoms of schistosomatous patients. But in the 1950s, the Chinese government put the much investment to invent the medicines for curing the schistosomasis of the patients. But at the beginning, these pharmaceuticals had very strong side effects, and that all the patients had to be congregated together, and they have to be taken care of by the doctors or the treatment team.
Question? Okay, thank you for that. Did you want to make something?
As Zhang and Bedahan already mentioned, the point of promoting traditional medicine within an integrative framework is becoming very important, and it has, I presume, been a practice in China for quite some time. So that to move away from this coexistence to have a kind of integrative, complementary approach of Western medicine and traditional medicine. And in that context, I was wondering, Dr. Fang, if you could elaborate on is kind of evolution or what we mean by integration. And is there a kind of pattern we can see how this integration has unfolded over the last decades, for example, in China? And I'd be also interested to hear a kind of personal assessment of that integration. I mean, has it been a kind of lip service, or what's been the substance of that integration? In that context, coming from a unit which is working on standards, I would be particularly interested to understand the process of integration. What kind of standards has or applied? I mean, it is a kind of model where you have traditional Chinese medicine with their own independent standards and Western medicine with their own independent standards being used in parallel, or there the idea of bringing them together into new standard where you take of everything to create something new. So I would be interested to if you could elaborate a little bit on what is meant by integration, what the history is, and what the underpinning model of that is.
Evolution of the integration of the Chinese and Western medicine. Western medicine arrived in China around the 19th century. Before that, there was no Western medicine. Medicine refers to Chinese medicine. And then in the late 19th century, the Western medicine has started to challenge, started to change the Chinese medicines in terms of the scientificness. And the first, the scientificness. And the second, is 19th century, and particularly after the late 1920s, Western physicians criticized traditional Chinese medicine for not being the scientific, and criticized the traditional medicine and traditional Chinese medicine doctors were obstacles for implementing the national public health programs, which is also associated with the nation-state building in the first half of the 20th century. But actually, that's the legitimacy debate between the Chinese and the Western medicines. But it was only legitimacy because in the first half of the 20th century, the majority of Chinese people not access to Western medicines. And the majority of a lot of Chinese peasants cannot access the traditional Chinese medicines. So, when Western medicines challenge the Chinese medicines' legitimacy, Western medicines, in terms of the medical knowledge, practice, institutionalization, and the professionalization, and gradually introduced into China, including rural China. And after 1949, after 1949, at the beginning, traditional Chinese medicine did not have the legitimacy offered by the state, but later, around 1954, the Chinese government legitimized the Western medicine, and then the integration of the traditional Chinese medicine and Western medicines was proposed and promoted nationwide. It was especially enhanced by the Barefoot doctor programs, but the integration of the Chinese and Western medicine was not balanced the process. I mean, the balance between the Chinese and the Western. Now, the Chinese Western medicine represents the 50%. The Western medicine represents the remaining 50%. So there was a very dynamic relationship between in aspects of the integration of the Chinese and the Western medicine. So in my presentation and in my book, I also analyzed how the Western medicines present the aggressiveness and the dominance when it faced encountered the Chinese medicine. And I think during this process, at the very beginning, the traditional Chinese medicine introduced the Western medicine into the China, and then the Barefoot doctors, because there were a large number of the Barefoot doctors during the late 1960s and early 1970s, and because of the reduction of the pharmaceutical prices, the villages could access the more and more the pharmaceuticals than before. So the integration of the Chinese medicine and the Western medicine becomes unbalanced. And the Western got the dominance in terms of in this integration. And the second is the mode of the stance of integration. Because I admit I'm not the medical, I'm not scientist. I'm only the medical historian, and I did the research through the perspective of the social history of medicine. But as far as I understand, in terms of a stance, its impact in terms of the stance of the integration of Chinese medicine as the medicine, I think the introduction of the Western medicine, one of the most important impacts of the integration of one of the most important impacts of the introduction of the Western medicine into Chinese villages or even the urban China was the organization of the Chinese medicine. And because of limited time, I did not make the conclusion in my presentation. So in my presentation, I would like to say that the decline of the Chinese medicine in rural China, the Chinese medicine underwent the process of the standardization, that's the patent medicines, and the second is urbanizations. So now the people in the urban China prefer the Western medicine, the Chinese medicine, the herbal medicine, or the Chinese material medica more than the villagers, more than the villagers do. And since the 1980s, and the third is the globalization. And you can see you can see a lot of the acupuncture clinics and the traditional Chinese clinics in the biggest cities of every country. So that's the three aspects: and urbanization and globalization. But these aspects are not change the basic trend that the Western medicine has already dominated the medical world of Chinese villages since the early 1970s.
I also just follow. Yes.
Oh, sorry. No, go ahead.
I just follow the Dr. Fang's the explanation. Yes. also agree with Lena that encouraging you as an expert on the history side, social history side, to make more how to say continue to the description of the medical history in China, particularly Chinese medicine, and particularly the recent years happening in China and also the whole country. Because after all, a barefoot doctor is a particular case during that period of time, and also regarding the question. Firstly, I provide some data because based on the latest survey, China that is published, I think later 2010, and actually is the existing figure of 2009. As traditional Chinese medicine service occupied 19% for outpatient, the whole health system. And for inpatient, it's 16%. Of course, this figure not including the rural as grassroots level service, including the community primary health care in urban areas. So you can see that still some big portion of the services. Of course, Dr. Fang always said is dominated by Western medicine. So in China, actually, yes. The general policy side to medicine and to traditional medicine, but always everyone is realize and agree that not means everything is 50%. Should be 50%. That it depends on how appropriate integrate. Because we see from WHO side, China one of the few countries we rather fully integrate. It means from policy side, the service side, from the tertiary hospital service to the those level community primary health care, from the service side to the health reimbursement from perspective fully integrated. So they need to also the policymakers also based on the need from the people, we level of service what they need and the facilities, how to keep the balance. Always the financial, always the resources. So this is the general figure. Also, Dr. Fang is correct that after the introduction of the Western medicine to China, they promote the standardization of this Chinese medicine. After 1950s, China established the university, the formal the education. Before that, just from the generation orally, no formal, particularly the university level, know that, and also the standardization is later the case. For some regulation side, doctors regulation, institutions regulation, let's combine as one. When doctors, the requirement is the same, something like that. And the technical side, they also now is working together, some independent. That's complicated.
Okay, so take this question that we've had from the internet from Zhang Almeida from the Max Planck Institute of the History of Science. So you can, I think, read the question. It's basically the recruitment of the barefoot doctors. Why are they called barefoot? Yes, question.
So the first question, the recruitment system of this barefoot doctors. So the blueprint of this barefoot doctor program could date back to 1930s. So in 1930s, there were already some experiments, rural health programs in Hebei and then Shanghai and Jiangsu. So these experimental programs selected the local the villages, the young villagers, and they provide the basic training, and after them to give the first basic treatment to the villagers, and undertake the public health work. And the latest, after 1949, this model was inherited by the new government. So in Barefoot doctor programs, the production brigades just select the young production brigade members and send them to study the medicine at the county health school. And then after the short and the brief training, when they return to the home production brigades, they did the similar work like the healthcare worker did in the 1930s. And for the second question is how they were received by the populations. Actually, before the mid 1960s, as you know, the many the pharmaceuticals and the doctors. So after the Barefoot doctors was promoted nationwide, it was welcomed. It was well received by the villagers. Though there were a lot, at the Barefoot doctors, the medical professions were very low at the very beginning. But after the 1980s, with the implement of the rural reforms, and Barefoot doctors were required to attend the medical examinations. For those who failed the medical examination, they were called a healthcare worker. So these medical examinations differentiate the Barefoot doctor in terms of the medical proficiencies. So the Barefoot doctor who still practice the medicine in the villages after early 1980s have the much higher medical proficiencies than these are the counterparts and then those the colleagues in the 1970s. And for the third question, how they were called the Barefoot doctors. So actually, it was in the mid 1960s, there was already one called one type of the worker called peasant health care work in Chinese villages. But this program has not been promoted and implemented nationwide at the time. But in Shanghai, this program performed very well, particularly in the suburban areas of our Shanghai municipality. Local people, this peasant healthcare worker carried the medical kits to rice paddies and participate in the labor with the fellow villagers at the same time. And so the villagers had something wrong with them, they just sought the basic to form these the peasant healthcare workers. So in China, particularly in the Zhejiang and Jiangsu low-Yangtze areas, the peasants labor in the field barefoot. They did not put on the socks and the shoes. So they were called, local peasants called them the barefoot doctors. So after 1968, this public health program, the peasant healthcare workers were promoted. This program in the suburban area of the Shanghai municipality was promoted, and this term, the barefoot doctor, was also adopted, and it was used to call this healthcare worker during the 1970s.
Before we get to the second question,
yes. Second question, of course. WHO, I think, for every document or report, we would like to use inputs from maximum inputs from the maximum including the historians. Of course, we are now building as large as possible the network for our work, and for particularly the strategy now is in the process development. We already request the comments for all the collaboration centers, the academics in the universities, of course, including some expert on history. And when we get the comments, we always welcome the inputs for our documents.
For
very quick. First of all, thank you for this most informative lecture I have heard here, because I've been part of this whole knowledge building of the traditional medicine program in WHO and in other organizations. But what I'm just saying is very quickly that I represent an association for channeling bioknowledge, myself a scientist affiliated to universities, and specifically requesting building in the knowledge base and the specific goal you have in the program for the next 10 years. The thought and the question raised recently on the integration, I think it would be a great way to take this subject forward, because we have so many things one can go on talking, but precisely it takes care of the works. For example, I am not going to go in detail like in India, the Central Research Institute or Central Institute of Medicinal Aromatic Plants and Traditional Knowledge Library and Kew Gardens and various institutions around the world. Besides what China's work has come now in today's lecture, I'm very happy if could somehow, as mentioned by the earlier speaker, on to a collaboration so that the final report reflects all these issues, if there is in that. Thank you.
Generally, some further information about the knowledge-based policy, right? Or what we're going to do.
Integration and
integration
for collaboration.
Collaboration. Yes. For example, in the always said in the early time, we try to build up as wide as possible the collaboration. In the future, we realized also the key issues very important. So, for example, now established a network of regulators on herbal medicines products. In the future, we are going to initiate the other network regulators for practice service side, practitioners, not only the product side. This is a formula for regulator policymaker side. The broader side is we are going to promote the relations with others. NGOs, we already have several international professional organizations with official relation with WHO and working relation. We are going to expansion, and also the other experts, academicians already, and of course other, including the local practitioners, healers, as wide as possible. 2 years ago, there is a conference of human resource for health in Bangkok, even there is a workshop. That's all the actually it's very famous for African region or Southeast Asian. So we are building wider and wider that kind of collaboration, and using other even we are going to set up even database for practitioners of traditional medicine globally. Encourage that side. For the knowledge-based management and policy, why we encourage this objective as one of the 3 key objectives, because now many countries in the daily practice or the need from the consumers there, but the government, particularly policy makers, not realize need or existence there. So we encourage them to recognize or make or anyway the data, what's the practical practices there every day, the need of the population, and also carefully identify particularly the user profile, who are providers, who are users, what's the disciplines or modalities of traditional medicine, daily practice there, and also keep in mind for the policymakers, the intellectual property protection. On the people side, traditional medicine knowledge, that's a very important issue. The other is the natural resources for herbal medicines, how to protect it and make it sustainable development. Even in China, it's a critical issue. We use a lot of, but some already very dangerous. next year will be no more the species or something that cannot be sustainable to serve the people's health. So this kind of also critical issue. WHO is going to develop a guideline anyway. We promote this kind of course, all this is based on the research and innovation. So research keeping the critical issue for the knowledge-based policy and the management. So this is very important. Of course, including the integration should be knowledge-based policy and to appropriately integrate based on the situation in your country, how to integrate appropriate policy and not the same model for all the countries. Traditionally diversify. The situation in country also diversify. The education side and the knowledge side. So anyway, welcome. Contact with you. Okay, thank you.
University and the China Centre for Health and Humanity at the University College London.
Okay, thanks so much for your question. As in my presentation, prescribing the medicine to support the barefoot doctor themselves has been a very serious problem since the early 1980s. So in order to solve this problem, the Chinese government recently implement the national catalog for the essential the pharmaceuticals. So the barefoot doctor could not, and in the meantime, the barefoot doctor were asked to join the rural service center, and they were not allowed to prescribe the medicine, and they just get the very basic salary. This is compared with the previous incomes over the past 30 years. These incomes were are very low. But I did my last field work on the barefoot doctor in late 2011. But because this program is being implemented, so honestly, I'm not sure how this program is implemented or was implemented over the past year, the last year. But that's the topic I will be exploring in the following months. That's all. Yeah.
Okay, I'd like to thank both speakers again. We've had a very interesting session, and thank you both very much for coming and sharing your knowledge with us. Thank you.